patients with atrial fibrillation in a community that you do not know of. So we're actually underestimating the number of atrial fibrillation that we have. And in Asia, certainly in East Asia, for Singapore and South Korea, Taiwan, Hong Kong, the prevalence of atrial fibrillation is about half of that of Europeans, even when you match for age. And this is our data from Singapore compared to Korea, and of course, American and UK data. What about South Asia? Well, we can look at Bradford. Bradford has a large South Asian population in the UK. And when they compared the prevalence of atrial fibrillation in their South Asian population, it's much less than the indigenous European population, even when we match for the age. And Singapore and Bangladesh are a bit different. We're an aging society with many more elderly people than younger people. Bangladesh is still a very young country in terms of number of youth. But of course, this will change over the next 20, 30, and 40 years. And you will suffer the same problems we're suffering now, an aging population. And what about risk scoring systems? The risk score system, CHAT and CHAT-VAS, were all developed in European population. In America, the CHAT risk score was developed in 7 American states. And in the CHAT-VAS as well, developed in European populations. So is CHAT-VAS and CHAT relevant to our Asian population, knowing quite well that the prevalence of AF is very different among Asians and Europeans? The Taiwanese has some data to adapt to their local population. They had to change the age cutoff from 65 to 50. And so you notice that the Taiwanese have a slightly modified CHAT-VAS risk score as well. So certainly I think each country, each ethnic group probably should develop their own CHAT-VAS risk scores and find what's best for themselves. And well, we know the prevalence is less in East Asians, but it's a propensity, the risk of causing AF the same. And we do have some data comparing East Asian and the rest of the world. The stroke rate for East Asian is much higher. So you have a much lower rate of AF, but yet when you have AF, your risk of stroke is much higher. We don't have placebo data, but this is the data when patients are either on warfarin or a NOAC, in this case, Xarelto. And of course, we have some subgroup analysis from India in the Garfield registry. Garfield is a worldwide registry of 51,000. We have a small subgroup from India. There's more diabetes, more coronary artery disease, more antiplatelets are used. They tend to have a lower median INR, and the all-cause mortality and mortality is much higher than the rest of the world. So in summary, the epidemiology is very interesting. Of course, there's increasing prevalence with age, and when your country gets older, there'll be much more AF. There's lower prevalence in both East and South Asians as well. And despite a lower prevalence, there's higher CV events in East and South Asians. And I think that CHAT-VAS needs to be recalibrated for each different country and each different ethnicity as well. What about AF in special population? Heart failure in particular. We know in Singapore that, again, the prevalence of AF is much lower in our Asian population, in heart failure population. So among a heart failure population, we have much less AF than compared to a mainly European population living in New Zealand. The risk factors for AF in our patients are the same: age, male, BMI, NYHA, BNP, AF, etc. What about AF in cerebrovascular accident? That means if you look at all the patients coming in with cerebrovascular accident, how many % of them have AF? In European population, it goes about between 8 to 20%. The number is different because of the pre-test population group we are testing on. In our hospital, we had a prevalence of about 7.7% of patients coming with cerebrovascular accident with AF if you monitor them for 72 hours. So about 3% of them, about half of them will have AF on arrival in A&E, and you have to monitor them for at least 72 hours to pick up the other half. So you double your pickup rate if you monitor them. So I think the standard now is to monitor all cerebrovascular accident, all strokes should be monitored for 72 hours, and some people are arguing for at least 1 week. So in special groups, in Asians anyway, there's lower prevalence but worse outcome, and in cerebrovascular accidents, there's similar prevalence, but we need to monitor them for much, much longer as well. And this is my patient. He complained of palpitations. I saw him in the morning. I said, why do you buy an Apple Watch? He went out and bought it, and at 2 p.m. he came back to me and said, look, this is what I found. So these wearable devices are changing the way we look after patients. He had micro AF, and we know that micro AF, although does not fulfill the definition of proximal AF, has a very high rate of becoming AF if you monitor them long enough. In fact, if you monitor them for 1 to 2 years, there's a 50% chance of micro AF being proximal AF, and with that, the stroke risk. So, what about anticoagulation? We're going to talk about AF and stroke, warfarin, NOACs, and of course devices. AF and stroke is now well recognized, but it was only about 1980 that we realized the link between atrial fibrillation and stroke. So it wasn't that long ago that we know that atrial fibrillation leads to stroke. Again, this was confirmed by the Olmsted County, is essentially the Mayo people. And then you notice, as far back as 1989, we know that aspirin does not reduce the risk of a stroke in AF. In 1989, but we only changed the guidelines a few years ago to take aspirin out of the treatment for stroke in AF. So aspirin does not prevent stroke in AF because AF is a venous thrombus and aspirin works on the vast arterial tree. So warfarin was discovered in the 1950s. It took about 55 years to find something to replace warfarin. So warfarin is good, but it was very, very hard to find a replacement. Warfarin still has a role in mechanical valve, rheumatic mitral valve. There's the LA thrombus. There's very little data for a new generation NOACs. Of course, in end-stage renal impairment, very controversial. Warfarin is affected by genes, by these two genes, the VCOR gene and CYP2C9 genes. There is some data to suggest that you can check for these genes to predict whether you should go high dose or low dose warfarin. And you can do this warfarin, you can check the gene and go to this website and get the dosage, the predicted dosage. What about Singapore? In Singapore, we have our own risk scoring system. Some people have tried to use genetic testing to predict how to use warfarin. You can reduce the chance of an overdose, but time to therapeutic range is the same, no much benefit. Certainly in our local data, we tried using the genetic testing to predict the warfarin dosage. No difference. That's because our time on therapeutic target range in our clinic was very good actually, because it's actually run by pharmacists who have PhDs. So if your center has very good pharmacists and doctors who are keeping a close eye on the warfarin, there's not much added benefit to doing a genetic testing. So genetic guided warfarin dosing, not much benefit if you already have expert prescribers. The cost and turnaround time, even for Singapore, is prohibitive, and there's more work to be done essentially. For the NOACs, especially in Asians, there's higher rates of hemorrhagic stroke in Asians, and there's less bleeding with the NOACs in Asians for dabigatran, apixaban, and also rivaroxaban or Xarelto. So lower bleeding risk and equal efficacy. And most clots in atrial fibrillation comes from the left atrial appendage. This was my patient from about 5 years ago. Very nice thrombus in the LA appendage. And of course, there's now an option of using the Watchman device. It's just as good as NOACs, and slightly better actually, with reduction of all-cause mortality. In the PROTECT AF data, it's slightly better than NOACs as well, and especially for people who cannot take warfarin. Okay, so in summary, AF is less prevalent in both East Asian and South Asians. the true prevalence is probably underestimated. The stroke risk, if your patient has AF, is same or higher, and the wearable devices are coming. Whether you like it or not, Apple Watch, Samsung Active 2, all will have ECG function, and patient will come to you with AF, micro AF, and you need to know what to do with them. There are China brands that are about 1/3 the price of Apple Watch. You can get them online in shopping, and one patient came to me with a reading from a Chinese watch, which costs about 200 Singapore dollars or about 150 US dollars. Compared to Apple Watch, is about 500 US dollars. Aspirin does not prevent stroke in AF. This is very, very important. We must stop giving aspirin for patients with AF. You are giving them the risk of bleeding from aspirin, but not the benefit. If you need to give aspirin, perhaps it's because they have concomitant ischemic heart disease or peripheral vascular disease, but do not give aspirin for patients with AF. NOACs are safer than warfarin. The data of East Asians are very, very convincing. I'm not sure about South Asians. Genomics, expensive. A lot of work still needs to be done for genomics. Devices, very expensive. Again, even in Singapore, my patients find it very expensive, but it's a viable alternative to warfarin and NOACs if they are bleeding from warfarin or NOACs. Warfarin, don't forget about warfarin. We still need warfarin for prosthetic valves, rheumatic valves, and LA-LV thrombus as well. With that, I thank you.
Thank you, Dr. Ong Hin Yi, for nice deliberation, the update of the management of the atrial fibrillation in terms of anticoagulation and the epidemiology in Bangladesh and Singapore perspective. But still, time is not finished. You can ask the question to Mr. Ong Hin Yi. Within this time, I request Professor Atahar Ali for preparing his lecture on interventional management of arrhythmia in Bangladesh. I request Professor Atahar Ali sir for preparing his lecture, and within this time, already 2 minutes time also is here, so you can ask any question to Dr. Ong Hin Yi.
এটা একটু উঁচু করা যাবে হ্যাঁ আরেকটা আচ্ছা ইয়া করি
What about the role of NOACs in mechanical heart valves?
I think we cannot use NOACs in mechanical heart valves. Yes, I think dabigatran had a trial with mechanical heart valve. There are much higher rates of thrombosis in dabigatran. So I think Xarelto, Rivarox, and Exavan, they didn't dare to run the trial, and they stopped the trial once the dabigatran data came out.
Thank you. Any other question from the audience?
In our country, we have only Rivaroxaban available in our country, and now Apex-7 also available. But what is your recommendation regarding use the aspirin in the South Asian people, especially for the Bangladeshi people, as because anticoagulant is most the costly drug in our country? Can you use aspirin? I think aspirin does prevent any anticoagulant effect, as because you have told that it works on the arterial line, and atrial fibrillation venous is the venous line. So we have to use either NOAC or warfarin.
The aspirin doesn't work. It just doesn't work for IF. And you're just giving them the risk of bleeding, unless they have something else.
Thank you, Dr. Ong Hin Yi. Now I request Professor Atahar Ali, consultant, Apollo Hospital, Dhaka, for delivering his lecture.
Very good afternoon, sleepy time. And the topic is arrhythmia. This is not the specific topic. Overall, the aspects of the electrophysiology in Bangladesh. I was requested to talk about this. And just for comparison, not just for the fun, if we compare the EP with the coronaries, both are the invasive procedure for the cardiology, you will see that the EP persons are slow like me, the coronary persons are very fast. EP, the patients are also like this, the corona is very aggressive like the heart attack. And the EP cath lab are always the oldest one in the hospital, but the newer one is, so this is the, and this is the reason possibly the EP comes many years after the coronary, and this is not in Bangladesh, everywhere. The EP is actually still in the growing phase in Bangladesh, and this is not very old. But before that, I want to start what about we know about the EP, particularly the electrophysiology, that is the EPS, is the study of the conduction system, particularly the conduction properties of the heart, not the conduction system. Actually, all parts of the heart except the coronaries can participate in that they have got the automaticity, rhythmicity, conduction, all the properties. And electrophysiology is the actually the study of the conduction properties of the heart, not only the conduction system. And all the parts of the heart can participate in the arrhythmia. This is the reason the electrophysiology. And radiofrequency ablation, this is the planned tissue ablation of the particular target area by applying the different kinds of the energy. So EPS and RFA, both the conjoined terms, and these are the meanings of these terms. And this is the fluoroscopic view of the electrophysiology. What we mean, that is, this is the invasive procedures. The dot means the electrodes, and these are the catheters are positioned in the different parts of the heart to get the electrical signals from the heart. So summations of these electrical signals is the study of the electrical properties of them, that is the electrophysiology. The history of the electrophysiology in Bangladesh, actually it starts in the 2004, and NICBD is the leading hospital. It was started in NICBD in 2004, and the first ablation of a patient was done in 2004 in NICBD. And device therapy, independent device therapy, not the device therapy. Before that, device therapy was done by some other persons from the abroad, but independent device therapy started in 2007 in NICBD. And I always feel happy to remember some of the persons, particularly here is the man, Dr. Rafiq Ahmed. Among these two persons, the man behind this, Rafiq Ahmed, he is the thinker, pioneer, founder of electrophysiology in Bangladesh. Still he is giving the supports. And another person I also happy to remember, this is the Dr. Anil Saxena. He works in the Indian Air Force Hospital. He always giving in the supports, and still now, me also including Saurabh and some other person, Dr. Tushar and Habib also get trained under him. Unconditional support by Dr. Anil Saxena. So these are the some of the persons, we must remember these persons for the development of the electrophysiology in Bangladesh. And actually, there are good number of the centers of EP in Dhaka right now. NICBD is still the leading positions. Then Apollo Hospital, Labed Hospital, Heart Foundation, Asghar Ali, CMAs, Impulse Hospital. These are the centers of the electrophysiology in Bangladesh. And this is the some approximate number of the electrophysiological interventional procedures what is happening in Bangladesh. There is the radiofrequency ablation, nearly 1,000 cases of the radiofrequency ablations done in different centers. Altogether, summation, nearly 1,000 cases per year. And diagnostic, it is not the ED, that is the diagnostic electrophysical procedures done nearly more than 100 cases per year. And ICD and CRT, I have taken the information from the companies, that is the, what they sold in the last year. Nearly ICD 75 and CRT 100 in the last year. So these are the approximate figures of the interventional procedures of electrophysiology in Bangladesh. And EP scope, initially, it was think for that. This subject was actually come to the field for the treatment of the tachyarrhythmia. But subsequently, also they also think about the bradyarrhythmia, and finally, the advanced heart failure, not all the heart failure. The clinicians also do that sometimes, but it is the advanced heart failure that is also under the electrophysiology subject for, as because these kinds of the patient needs some of the device therapy. So these are the fields of the electrophysiology. Tachyarrhythmia, actually, tachyarrhythmia is a huge burden. We don't know what is the number of the population, that is the patients, but statistically, globally, 3 per 1000 is the number of the, that is the prevalence of the SBT in, this is the global data. So if we calculate, there is 160 million people in Bangladesh, so huge number of the SBT patients in the Bangladesh. And atrial fibrillation, you know, it is the approximate figure, nearly 1/3 of the patients having age of the 66 or more, they can have the atrial fibrillation. So this is also the one kind of the, that is the one of the most consistent and the most common and stable arrhythmia in the population. Also the PVC, almost nearly more than 1% of the general population has got the symptomatic PVC. And nearly the structural heart disease patient, nearly 10% of the patients with the structural heart disease has got the PVC. So there are a huge number of the tachyarrhythmia patients. And these are the two ECG you can see. These are the braid of the electrophysiologist. The upper one, this is the narrow complex regular tachycardia, likely to be the SVT. So this is the braid of the electrophysiologist. The lower one is also, this is the wide complex regular tachycardia. So this narrow complex and wide complex, these are the always the things about these electrophysiologists, what are their diagnoses and what should we do. So if this is wide complex, then it can be the VT or SVT with aberrancy, or ASBT with the bundle branch block, or the pre-excited tachycardia. So these are the braid, and this is the butter. So these two ECG comprises nearly more than 80% of the electrophysiologist work. The previous one and this one. The upper one is the clinically they manifested the delta wave, that is the WW syndrome. The lower is the also they can produce the SBT, they have got the concealed WPW, that is the concealed accessory pathway, and both of these can produce the narrow complex tachycardia. So this one and this one, these are the bread and butter for the electrophysiologist. Complex nearly more than 80% of the electrophysiologist work. But sometimes there are some difficult works like this. The upper one is the regular narrow complex, likely the SBT, but if it is the irregular, then there is some problem. This is always got surveillance, there is that atrial fibrillation, MET, or the atrial flutter with variable work. So these are some examples of the ECG, and these 4 examples includes almost nearly all kinds of most of the common types of the arrhythmias. And these are the ECGs that we have to deal all the time. This is the works of the electrophysiologist. There are some complex ECG like this. This is one of the examples of the long RP tachycardia. If this is the long RP tachycardia, this is the real challenge for the electrophysiologist. There is no way other than the electrophysiologist can give the solution. Examples are the AVRT, atypical AVNT, atrial flutter, or the tachycardia. This is the clinical discussion, but final diagnosis will be in the lab of the electrophysiology. So these are the complex arrhythmia. We also deal these kinds of the arrhythmia also. And now this is the era of the 3D electrophysiology. And by the 3D electrophysiology, we can do some of the cases, that is the atrial fibrillation, flutter, PVC, or the VT with the structural heart disease. And this is the atrial flutter. We can by cure these kinds of ECG. And PVC is one of the challenges, and PVC can be easily cured by the 3 dimensions. This is one of the examples of our cases. Here is the PVC. The PVC in the V1 lead is LV morphology, but there is a slight R that shows this PVC may be from the left sided, and by 3D mapping, it was found that this PVC comes from the that is aortico-mitral continuity, just below the coronary arteries, left main coronary arteries is above. This is the area for that kind of the PVC, and it can be successfully ablated. There are some kinds of the complex arrhythmia like this. This patient has got the atrial septal defect, left-sided IVC, there is no right-sided IVC. That IVC goes through the persistent left superior vena cava, opens into the right atrium, so it is difficult job for this ablation. So it was done from the jugular approach, and we can deal like this kinds of the complex ECG. And also we can do the heart failure cases, that is this is the ICD, we know the indication. This is the CRT, we know the indications. And sometimes we also deal the complicated, that is the complex ECG, that is complications after the CRT therapy. This is one of the examples. The CS lead is drawn into the brachiocephalic vein. We can again, initially the patient did not have confidence for treatment these kinds of the procedure, but now this patient can get confidence that we can do this procedure, and we have done this, and this is the final procedure. And not only this, there are some alternative pacing procedures like this. In contrast to the classic CRT applications, we can do the some conventional modified CRT procedures that is included in the, this is included in the guideline, that is the RA-LV pacing. That is those patients who has got the complete heart block with LV dysfunction, these are the classic indication for the CRT. But those who cannot afford the CRT, these patients can be treated by this kinds of the procedure, that is RA-LV pacing. There is another kinds of the rewarding procedures like this, that is the His bundle pacing, lead bundle pacing for the patients who has got the non-responsive for the CRT procedure or who has got the non-LVB morphology or the RBB morphology. So these are the cases, that is the LVB pacing. So all kinds of the interventional procedures can be done in Bangladesh. So thank you very much for your kind hearing.
Thank you, Professor Atahali, for briefly and nicely introduction of the electrophysiology situation in Bangladesh. But time is very short. I now request the Professor Mohsin Hussain for delivering lecture on 3D mapping in electrophysiology. Within preparing the next lecture, if anyone asks a question, you can question to Professor Atahali regarding EP study.
Sir, I have a question to Professor Atharali, sir. For poor man's CRT, you asked that RA pacing and LV pacing. What is the LV lead? It is the LV lead that used in CRT placed in coronary sinus, or it is the RV lead placed in the coronary sinus?
This is the, not the RV lead, it is the CS lead. There is the coronary sinus lead.
And the generator
is the normal
pacemaker, dual chamber pacemaker.
Normal dual chamber pacemaker, and it is the coronary sinus lead. That is so you can say it is a modified CRT. And in case of the LB pacing, that is the lead bundle pacing. Here it is the normal our VBI or the dual chamber pacemaker, and the lead is separate lead. The lead is not these kinds of the RV lead that have the special type of the screwing system. That is a separate lead. So for the LV pacing or His bundle pacing, the leads are separate.
Sir, many times we found patient with LV dysfunction and need pacing for bradyarrhythmia. And this type we are confused. The patients are poor, they cannot afford the CRT. So in that case, the CRT is indicated even though the patient is asymptomatic for heart failure, and even though the QRS complex is LVBB or not. Sir, so there is a strong indication of CRT in that cases. But sometimes our patient cannot afford. What should we do? One is the poor man's CRT one, and in other cases?
Yes, this is the good news for these kinds of the patient. Actually, these are the huge number of the reports. Hopefully, this may come in the next guidelines. That is the lead bundle pacing. His bundle pacing is not superior as because there are atrial oversensing, lead dislodgement. There are some limitations of the His bundle pacing, but the lead bundle pacing is more courageous. And these are the groups of the patient. Those who are not response to that, does not respond to the conventional CRT, that is non-responder. Those who have got the RBB morphology or non-LBB morphology or Brady pacing, that is the bradycardia that needs the pacemaker and has got the LV dysfunction. These are the huge number of the groups of the patients. These are the indicated for the initially His bundle pacing, now for the lead bundle pacing. And for this reason, they are also candidate for the RALV, but RALV is not so superior. This is the more superior actually.
Sir, for left bundle pressing, we have to go through the RV or go through coronary sinus?
No, through the RV. Same approach from the RV. There is RV, His area, just distal to the His area, that is the lead bundle area. But you need the help of the EP, that is His bundle catheter.
Yes, thank you, sir. Thank you very much.
I just add something. LV pacing is still, that is off-label indication. It is still not in recommendation accepted. It is just off-label indication.
Before getting ready, I want to share my experience. Two calls I get from my ICU. One, the patient is at, sir, are you ready, sir? Oh, thank you.
Thank you, Professor Atahalali. Now I request Professor Mohsin Hassan, cardiologist and electrophysiologist and Professor of Cardiology and ICVD, for delivering lecture on 3D mapping.
Assalamu alaikum, good afternoon. I am going to present with 3D mapping and ablation of complex arrhythmia in NICVD. Atas sir has described the development and establishment of EP in Bangladesh, and he described the all aspect of EP. And 2018 we started 3D mapping and complex arrhythmia, and we are showing this. In left side you can see the EP mapping system, and the right side you can see the mapping catheter. This is 64 electrode catheter, 2 millimeter space. So the mapping time is very quick with one kind of basket catheter, and you can map the LA, RA, LB quickly, and annotation, that is the mapping accuracy is very 99.9%. So this is made by Boston Scientific. NICVD has got this system, and we have done the case. This system is high density. The mapping system density is high, and the resolution is high resolution, and is the annotation is automatic. That is high density, automatic. You don't have to collect the point by manually. So device will collect them manually. Indication of 3D mapping is the complex arrhythmia, likely atrial tachycardia, atrial fibrillation, atrial flutter, PVC, burden if more than 10% or LV systoolic dysfunction, ventricular tachycardia, and some form of SVT if the conventional EP system does not work. From 2018 we have done 44 cases. One patient of atrial fibrillation, after completion of 4-vein isolation, he patient developed hypertension and echo show pericardal component, and we successfully pericard synthesis done, and patient survived, and patient is doing well. You can see the number of the patient. The 13 patient is atrial fibrillation, atrial flutter is 6, atrial tachycardia is most difficult and challenging all over the world. It is 6, ventricular tachycardia 2, PVC, premature ventricular tachycardia is 11 patient, and accessory pathway 6 patient. I have studying with on cases, 53 years female, hypertension, he has paroxysmal AF for 2 years, his coronary angiogram is normal, and echo is normal. ECG you can show, this is irregular complex, that is atrial fibrillation, you can diagnose easily. This is the 3D mapping system. 3D mapping system, we need to go to the left atrium. So we have to go to transeptal puncture. We need 2 puncture, 1 puncture for the mapping and 1 puncture for the ablation catheter for ablating the all 4 veins to disconnect from pulmonary vein to the left atrial appendix. So you can see here the whole pulmonary vein. Here pulmonary vein, the all pulmonary vein you can see here. This is the signal. This is the signal of the pulmonary vein. This is the catheter. This is the Orion mapping catheter. Mapping catheter is taking signal from the pulmonary vein. So when we ablate the pulmonary vein, the signal is disappeared. So this vein is disappeared. The right superior pulmonary vein is disappeared after this ablation, and it is the right superior pulmonary vein, and you can see there is no signal. There is no signal in the Orion catheter. This is mapping catheter in the pulmonary vein. So the pulmonary vein is completely disappeared, isolated from the left atrium. This is the left superior pulmonary vein, also isolated. Another case is Mr. S, 36 years, he is hypothyroid due to a long-term amiodarone, and he has palpitation, and PVC burden is 20%. You can see here, this is the PVC, you can see B1 is negative, 2, 3 were positive. It is most likely right ventricular outflow tract. So we decide to do the ablation. The right ventricular, we can see here the 3D mapping system. You can see, we can map the right ventricle outflow tract, but there is no earliest sign in the right ventricular outflow tract. So we map the aortic cuffs. So the earliest red point. You can see the earliest red point is the earliest point from from where the PVC is coming from. So the red point from the left aortic cuffs. You can see here, this is the left side, that is the RV, and right side is the, you can see the aorta. So it is coming from the, you can see the red point is come from the aortic cuffs. So we map from the, we confirm, and ultimately we give this, you can see here, we shoot the, you can see here, this is the right coronary, the left coronary, this is the right coronary, and this is the right coronary cuffs. So this is the target site of the PVC. We ablate, and there is no PVC, so PVC disappears. So post-ablation, there is no PVC. So it is very difficult. This patient also, after 72 hours, 42 hours, 24 hours, he developed stroke, most likely from the, so after he recovered well. So if you want to burn in the aortic cuffs, and if there is some embolization, so it is very difficult to, because we use some reused catheter, so this is one of the major cause, maybe the some. Another case, 26 years male, palpitation 1.5 years, he 2-time refractory, that is the right atrial, that is the RFA, failed by the 2D system in Bangladesh, and CATO, this is one of the 3D system, failed in the India also, and open heart biopsy was done big due to refractory arrhythmia, because the patient cannot tolerate. So the biopsy revealed that there is a lot of scar in the whole right atrium. She thought that there is maybe sarcoidosis or some things, they give long-term steroid, but the tachycardia persists. So this high density mapping system, this is the ECG, looks like HBT narrow complex. Sir is told this is the AT, the long RV tachycardia. This is the tachycardia in the PLAB. This is 1:1 tachycardia. You can see here, we can map with the Audion catheter. The earliest sign is the right atrial appendix. All the gray area, you can see all the gray area is the scar. So this is the tricuspid valve. So the tachycardia arising from the right atrial appendix. So we can, you can see the red area, we mark the red area. This is the origin of the tachycardia. We ablate here and tachycardia terminate. And still the patient is doing fine. Another case, this is post-MBR patient. He has refractory heart failure, several times on admission in the hospital, and we did cardioversion, but the patient developed refractory heart failure due to atrial tachycardia, and patient developed hypothyroidism due to amiodarone. So we decided to do, that is the 3D mapping system. So the patient had 5 atrial tachycardia induced in the cath lab, and we update all the 5 tachycardia. You can see here, this is the 12B disease of the AT, the narrow complex tachycardia, long RV tachycardia. This is the transeptal puncture. You can see the, that is the mitral valve. So transeptal puncture. And this is the mapping catheter. This is the, we can map the right atrium and left atrium. We map, and you can see the earliest sign is from the LA loop. This is the red sign. This is the origin from the left atrium. This is the tachycardia, origin from the AT. We ablate there and tachycardia disappear. So this is 5 tachycardia, same left atrium, and we ablate all the 5 tachycardia. After RFA, this tachycardia becomes sinus. Case 5, Mr. X, this is PCI to LAD, LLCX, and 65 years, and persistent atrial flutter. We can see the flutter wave. Why is it 4:1 flutter? This is the 3D mapping system. We can see here how the flutter wave is going on. The map is right at, so this is the, you can see, this is the SBC, this is the tricuspid valve, this is the inferior vena cava. The tachycardia is coming from this common, this is isthmus dependent atrial flutter. So we, after mapping, just we draw a line from the, there is the CTI line from the tricuspid annulus to the inferior vena cava. We complete the line, the tachycardia terminate, and patient is doing well. This is the after sinus rhythm, this patient is doing fine. Thank you very much for patient hearing.
Thank you, Dr. Professor Mohsin, for nicely delivering on 3D mapping, electrophysiology. I request the next speaker, Dr. APM Surahmat Jaman, giving these topics on important topics, sudden cardiac death, or approach for the management. Within this time, if anyone want to ask the question, you can ask the question to Professor Mohsin.
Any question to Dr. Mohsin regarding 3D mapping?
In 3D mapping, we see different colors are coming like that. So eco, there is some set rules, blue and red. Whether there is any set rule so that you can understand which color is for what, what's really going on. There are different types of colors coming and going.
And I told this the red, this is the color, the rainbow color. The earliest or the color is the red color, is the earliest color, then yellow, then green, then blue, then orange. The orange, then blue. So this is dependent on the color. The earlier red color, if the red color, this is the original site. This site from what the ticket is coming on. Then the yellow, then orange, then last is the
Actually, it's operator dependent. You can change the color according to your choice in the machine. You can start, the blue is the starting point. This is when it emits blue, that is the point from where the ectopic rhythms starting. So you can change according to your choice.
I ask another question, Professor Mohsin. Is the 3D mapping? Because it is a 1 year experience in Bangladesh, nearly. So what is the comfort or success rate is improved within 3D mapping over the 2D mapping? Because possibly it is not available in other EP center.
No. Athasar is doing EP, the 3D mapping in the Apollo also
3D
started.
mapping is now in 3 institutes.
Or 3 institute, right?
So the conventional 2D mapping is this complex arrhythmia. I told you that this atrial tachycardia, it is impossible. It is very difficult to identify with the 2D mapping. Atrial flutter is very easy to 3D mapping. Atrial fibrillation, without 3D mapping we cannot do it. The ventricular tachycardia, you need to, it can be done by 2D, but 3D is more feasible.
Earlier, atrial fibrillation was done in 2D map, conventional EP with the lasso catheter. The ring type catheter, the tip is like a ring. It has multiple electrodes put into every pulmonary junction with the left atrium and used to ablate circularly. With 4, after completing 4, some lines were drawn on the left atrial wall. That usually used to terminate the atrial fibrillation, but it is very cumbersome. It takes 5-6 hours to complete a case. But 3D mapping is so easy, you can understand from where to it ablate. And the catheters also came, so say one basket catheter. Some balloons are there. You put the balloon in the pulmonary ostium, venous ostium, ablate. At a time it gives a circular burn. So it became very much easy when the 3D mapping and the newer generation of catheter are available.
Thank you. Actually, it's a blessing for the refractory arrhythmia patient. Possibly, sir, ready, sir? One question. No, okay.
I have a question to Mohsin Ahmed sir. Sir, may I know the mortality rate of EPS and ablation globally?
The mortality rate of SBT is nearly very few. And we are doing the EP for last 2004 to, so very negligible number 2D system SBT, there is no mortality. But 3D system, when you do the BT or AFib ablation, there is chance of perforation and patient can die with the tamponade if you cannot assist. So there is 3D system complex arrhythmia. So in that case, there is a perforation of the desired ventricle or desired TM, and that can go to the tamponade and the patient can die. So with our 44 cases, one patient did tamponade after finishing the ablation, and we saw the patient is hypertensive, sweating. We do the echo, there is a effusion, on pericardial synthesis, patient doing well. And one patient developed stroke, and subsequently he improved. So by complex arrhythmia, there is a chance of refractory VT. If we do the VT ablation, in the left ventricle, so there is a chance of also there is a mortality because morbid patient, low ejection fraction, scar, refractory VT, repeated cardio shock, cardioversion. So the high risk patient, there is chance of mortality.
So there is no mortality in our NSCVT yet now.
Yet now, no mortality.
Thank you, sir.
Thank you.
Professor Boshin, how is the incidence of developing coronary heart block in your personal experience while working since 2004?
Initially, when in 2004, we have 4, 5, 6, 7. Up to 2007, we have some come. After 2007, till now, I don't have any person complete heart block.
Thank you, Professor Mahashinushan. Now, sudden cardiac death is maybe the maybe presentation of the ischemic heart disease. So, the junior doctors and also we have to refresh our knowledge regarding how to manage this case. Now, I request Dr. APM Surahmat, Director Cardiac Cath Lab and Heart Rhythm Services, Labet Cardiac Hospital, for delivering a speech on sudden cardiac death, approach for the management.
Good evening, everybody. Sudden cardiac death. Okay, here I can, huh? Sudden cardiac death. We know the definition. যাচ্ছে না? তুমি তো আমার time নষ্ট করলা বাবা। যাচ্ছে না? Definition of sudden cardiac death. SCD is defined as natural death due to cardiac causes, heralded by abrupt loss of consciousness within 1 hour onset of acute symptoms. Pre-existing heart disease may have been known to be present, but the time and mode of death are unexpected. So my topic is sudden cardiac death. When death is occurred to that person, none of us in this hall room have to do anything. Then it is the duty of the priest or the purohit or the maulanas. What we can do? We can do something before the death. So, definition of cardiac arrest. Sudden cessation of heartbeat and cardiac function resulting in loss of effective circulation or absence of systole, failure of the ventricles of the heart to contract, usually caused by ventricular fibrillation, with consequent absence of the heartbeat leading to oxygen lack and eventually to death. What is recommended? Defibrillation, chest compression, oxygenation, medications and procedures. This is the importance of defibrillation. Chance of success decreases with 7 to 10% with each minute elapsed after the cardiac arrest. Where is the new chains of survival? Chains of survival is in-hospital cardiac arrest and out-of-hospital cardiac arrest. First recognition, chest compression, defibrillation, then cath lab or in ICU. In out-of-hospital, first recognition, call the help, then chest compression, then AED can help, defibrillation, then emergency medical services, then to the cath lab and ICU. And what the ACLS highlights say in 2005, that is the CPR adjuncts, that is impedance threshold device and active compression device. This device, I think only we have got impedance threshold device in the form of endotracheal intubation. Impedance threshold device and active compression device, when it is combined together, the result is better. You can see in the graph. And what is the recommendation? The routine use of impedance device as an adjunct to during CPR is not recommended. It is not available everywhere. There is insufficient evidence to recommend for or against the routine use of ACD CPR. ACD CPR may be considered for use when providers are adequately trained and monitored. The combination of ITD and ACD CPR may be reasonable alternative to conventional CPR with available equipment and properly trained personnel. This is the mechanical CPR load distribution band and mechanical piston. And mechanical CPR, you can see the survival with good neurologic function, only Lucas gives, others all are manually compression, by manual CPR is better, but when you use Lucas, that device is showing better. And what is the treatment recommendation? by the AHNECC. Manual chest compression remains the standard of care for the treatment of cardiac arrest, but mechanical piston and load distribution bands devices may be reasonable alternative for use of properly trained personnel. The use of mechanical piston or load distributing band device may be considered in specific settings where the delivery of high quality manual compressions may be challenging or dangerous for the provider. Limited rescuers available, prolonged CPR during hypothermic cardiac arrest in a moving ambulance in the angiography suite during preparation of extracorporeal circulation, provided that rescuers strictly limit interruptions in CPR during deployment and removal of the device. Recommendation update, what the updates say. Either back-mark ventilation or an advanced airway strategy may be considered during CPR with adult cardiac arrest in any setting. If an advanced airway is used, then supraglottic airways can be used for adult with out-of-hospital cardiac arrest in settings with low tracheal intubation success rate or minimal training opportunities for endotracheal tube placement. If an advanced airway is used, either HGA or ETT can be used for the adults with out-of-hospital cardiac arrest in settings with high tracheal intubation success rates or optimal training opportunities for endotracheal tube placement. An advanced airway is used in in-hospital setting by expert provider trained in these procedures, either the HGA or ETT can be used. Frequent experience of frequent retraining is recommended for providers who perform endotracheal intubation. Emergency medical services system that perform pre-hospital intubation should provide a program of ongoing quality improvement to minimize complications and to track an overall HGA or ETT placement success rate. Then vasopressors. Vasopressor, that is return of spontaneous circulation achieved with pre-hospital and admitted hospital. Survey to hospital teachers, there is no difference, but showing difference. That a high dose epinephrine. High dose epinephrine is also not very pleasurable because the p-values are not very quite high. Time of administration of epinephrine outcome in hospital care with non-shockable rhythms, retrospective analysis of a large in-hospital data, time to administration of epinephrine, you see the survival to discharge decreases with increasing time. Treatment recommendation, a standard dose epinephrine, 1 milligram every 3 to 5 minutes may be reasonable for patients' cardiac arrest. High dose epinephrine is not recommended for routine use in cardiac arrest. It may be reasonable to administer epinephrine as soon as feasible after the onset of cardiac arrest due to an initial non-shockable rhythm. Recommendation is standard dose have been updated. We recommend the epinephrine for be administered to patients with cardiac arrest. On the basis of protocol used in the clinical trial, it is reasonable to administer 1 milligram every 3 to 5 minutes. High dose epinephrine is not recommended for routine use in cardiac arrest. Vasopressin may be considered in a cardiac arrest, but offers no advantage as a substitute for epinephrine in cardiac arrest. But combination, vasopressin in combination with epinephrine may be considered during cardiac arrest, but offers no advantage as a substitute for epinephrine alone. Either with respect to the timing of cardiac arrest with non-shockable rhythm, it is reasonable to administer epinephrine as soon as feasible. With respect to the timing of cardiac arrest with shockable rhythm, it may be reasonable to administer epinephrine after initial defibrillation runs have failed. Then physiologic monitoring. Although no clinical studies examined whether titrating resuscitative efforts to physiologic parameter during CPR improves outcome, it may be reasonable to use physiologic parameters. That is, that parameters are quantitative waveform, capnography, arterial relaxation, arterial diastolic pressure, arterial pressure monitoring, and central venous oxygen saturation. When feasible to monitor and optimize CPR quality, guide vasopressor therapy and detect return of spontaneous circulation. Prognostication, end tidal volume CO2. There is died in hospital is when the tidal volume is high, p-value. Initial it was, final it was like this. Then you see the survivors become better. End tidal volume prognostication during CPR. In intubated patient, failure to achieve end tidal volume greater than 10 mm by waveform chronography at 20 minutes of CPR may be considered as a component of multifactorial approach to decide when to end resuscitative efforts, but it should be used in isolation. The above recommendation is made with respect to EtCO2 in patients who are endotracheal intubated. In non-intubated patient, the specificity to cutoff value at any time during CPR should not be used as indication to end resuscitative efforts. Cardiac ultrasound, these are the 4 cardiac ultrasound. What is the treatment recommendation? Ultrasound, cardiac or non-cardiac, may be considered during management of cardiac arrest, although its usefulness has not been well established. In a qualified sonography is present, use of ultrasound does not interfere with standard cardiac arrest treatment protocol, then ultrasound may be considered as an adjunct to a standard patient evaluation. That is percutaneous extracorporeal membrane oxygenation during cardiac arrest. What is the treatment recommendation? There is insufficient evidence to recommend the routine use of eCPR for patients with cardiac arrest. In the setting where it can be rapidly implemented, that is extracorporeal CPR may be considered for selected patients in whom the suspected etiology of the cardiac arrest is potentially reversible during a limited period of mechanical cardiorespiratory support. There is insufficient evidence to recommend the routine use of eCPR for patients with cardiac arrest. eCPR may be considered for selected patients as acute therapy when conventional CPR efforts are failing in settings which can be experientially implemented and supported by skilled providers. Coronary angiography should be performed emergently in out-of-hospital patients with suspected death. Consistent with all other STMI cares, neurological ultrasound are knowable at time of decision. Many observational studies showing the high rates of good outcome after PCI, as soon as successful PCI with better outcomes. Non-ST elevation MI also shows good result. Immediate percutaneous ST elevation MI, you see, successful PCI has got good outcome. What is the recommendation? Emergency coronary angiography is reasonable selective for adults who are comatose after OHA and suspended cardiac arrest without ST elevation and ECG. Coronary angiography is reasonable post-cardiac arrest patient whom coronary angiography is indicated regardless of whether the patient is comatose or awake. Now, cold, temperature. Temperature to be targeted temperature regulated between 33 to 36 degrees centigrade. And TTM recommended for all patients in whom comatose following ROSC for cardiac arrest. TTM selected maintain constant temperature between 32 to 36. In all patients still comatose, continue treatment beyond 24 hours by actively preventing fever. Routine pre-hospital cooling with patients with rapid infusion of cold IV fluids is not recommended. The earliest time to prognostic a poor neurologic outcome using clinical exertion patient not treated with TTM is 72 hours after cardiac arrest. Can be even longer than 72 hours after cardiac arrest itself. If the residual effect of sedation or paralysis confirm the clinical examination. The earliest time of prognostication using clinical examination in patient treated with TTM when sedation or paralysis could be confirmed maybe 72 hours after return of normal pressure. Summary. ITD alone not recommended. Dr. O'Neill is not here. ITD alone not recommended, but ITD ACT CPR may be improve outcomes. Mechanical CPR not superior to manual CPR. Epinephrine unchanged as possible removed from the algorithm. Prospectively validated physiology goals needed to goal-directed CPR. End-tidal CO2 less than 10 mm market after treatment CPR indicator of futility. Potential role of focused ultrasound but remains unproven. Growing evidence supporting eCPR but clinical trials needed. Early post-arrest coronary angiography and PCF indicator recommended for STMI and non-STMI. Widened therapeutic range of hypothermic TTM and pre-hospital cooling with cold IV saline not recommended. Reliability of early neuroprognostication remains limited. Thank you.
Thank you. We are at the nearly end of the session, really, because unavailable session, Dr. O'Neill Saxena is not present here. So we can allow some questions from the audience, because we have time. And this is the last topics in this room.
I like to add something about Drs. Min Nesaruddin, because sir, Debigatran and Apixaban and Rivaroxaban, all three are available in Bangladesh. We are not poor.
Any question?
And one thing I like to add it with Dr. Atar Ali, along with NICVD started fast. In June 2004, I think, no? In June 2004, we started with a, what we can say, Dharkara lab diya. We have started electrophysiology in September 2004. There was a gap in between, then we fully started 2D mapping system in 2006 in lab at Cardiac Hospital.
Actually, it is a expensive some EP procedure, but because the 3D mapping is now available, because in the 3 hospitals in Bangladesh is now doing EP study. So how much, sir, because you are the working in the peripheral hospitals, sometimes we are referring the patients. most of the patient cannot do this because of the probably of financial problem. So what is the costing of the
expense varies from hospital to hospital. In
Three-
private sector, it varies a lot. In my hospital, I can say, in Asgurali, we take 30,000 for EP study and 30,000 for RFA ablation. And how to?
And in our hospital, especially we are doing AVNRT and AVRT, not all sorts of arrhythmia, especially AVNRT and AVRT. For EP study, we take 30,000 and for ablation another 10,000, only 40,000 in heart function hospital.
3D mapping with 3D
But
mapping?
3D mapping is much more expensive. But in NICVT, it costs nothing, almost 5,000 or something like that. But in Apollo, it would be more than a lakh. Otherwise, it's more than a lakh.
In NICVD, EPS RFA only cost, government charge is 5,000 taka. And 3D system also same. All the catheter, everything is separated by the government.
3D mapping made easier
Easier.
to ablate atrial fibrillation, VT and PVCs. And you can also assess the ventricular muscle mass by 3D mapping, how much the scar burden is there and how much the ablation going to help the patient. But with conventional EP, scar burden cannot be assessed.
That's why it's more.
Yep.
So thank you very much for giving me the opportunity. Here, all the giant and legend EPS specialists are here. So may I humbly request you all, because a significant number of patients are coming from the pediatric population. So we have to develop the pediatric EPS specialist. So may I humbly request you to please pick up some person from the pediatric cardiology background to train up for those vast number of patients to care.
Few days
Although-
back,
although you are
few days back, I was in your program. I have, in that program, I was invited by Dr. Salam, Dr. Jahid, to talk about EPS in children. So I told them, you are doing all the structural heart disease. A number of pediatric cardiologists now developed skill to intervene the congenital heart disease. But one of you must come forward. Must come forward to learn EP. But because EP is very dangerous in a child less than 4 years of age. But you may need it. I have seen so many patients of Dr. Nurnar Fatima admitted in Labate Cardiac Hospital, 2 years old baby having incessant SVT. Heart rate remains 160 throughout the whole day and night. So I am pity for them. But now my request is to develop EPS, pediatric EPS. We, Atar and myself, Sadi is there, Moshin is there, we can help to get training. We can help through our Bangladesh Heart Rhythm Society to get training abroad for pediatric EPS. Okay?
Sir, another question, sir, I can ask. How many EP specialists in Bangladesh now?
You need a dedicated fellow.
It is difficult.
Dedicated fellow.
You don't have any.
Otherwise, it's not
I think
possible
the-
to learn EP
But
especially for the pediatric patient.
according to the statistics of the
Mohsin,
world,
I
2
think you-
per 1,000.
According to Salam sir,
make it-
one of the
make it
electrophysiologists from the USA, he's a professor of electrophysiology, pediatric electrophysiologist, comes frequently to Texas University. He came here and he did 3 cases with the help of, because we cannot manipulate the pediatric catheter. So they have, we need the, because we are very much afraid about because of the anesthesia, general anesthesia. So puncture, everything is very delicate. So pediatric patient dealing is very delicate. So pediatrician who are doing intervention, if they can do the puncture, they can do the placement of the catheter, and we can help the mapping and ablation. In India, I have sent one patient in 9 months, and incessant tachycardia refractory to that is the shock. I sent to the Mumbai, and then Bharat Dalbi is doing all the catheter, everything, and another EP guy, he's doing just ablation. So it can be combined. They can, if they can do the puncture, they can do the catheter manipulation, and we can do the ablation. This can be possible.
যদিও দেরি হয়ে যাচ্ছে আর কি, মানে আমি সাপ্লিমেন্টারি বলছি স্যারের সাথে, সেটা হচ্ছে যে ফান্ড ইজ নট এ প্রবলেম. Those NGO who are bringing those fellows from USA, this Qatar Red Crescent, they are willing to provide all the catheters and other accessories for pediatric use. But we could not find any company to provide these hardwares in Bangladesh.
Actually, pediatric cases are less. So the
cases
company,
are
no,
not
so the
less.
vendors will not bring those pediatric catheters. Those are much expensive than adult catheters, and number of cases are less. They will not import it. That's the main bar to do pediatric EP in this country.
The thing is that the first RFA was done in September 2004 in my hospital by a hired instrument. So we can hire an instrument. We need a person who is interested to learn EP in children. Select the person. We can send him or her to appropriate centers.
Jamil Bhai, because there is a pediatric ICU in the NICBD, so every day a lot of patient is referred to all of the Bangladesh. I have to I have to calculate the pediatric dose, because every day they call me to see the patient. So a lot of patient is admitted in the.
Patients are there, but agreeing for EP, very less.
Okay, thank you.
So there will be another session probably.
Now, sir, now in session for the memento distribution, I now request now Professor Atahali to come in the dais. And the dais from the Dr. Abdullah Al Jamil. Now, I request Professor Mohsin Hussain and Professor Dr. APM Saroj take the memento from the chairpersons and give the big hand to all the speakers. Thank you, the speakers and also the audience for active participation, for make the session lively. Now I request the chairperson for the concluding remarks.